Just give us a second, sir.
Yeah.
Deepika, you can proceed.
Okay, thank you everybody for joining. Today we have Dr. Amitabh Banerjee with us. So the topic of discussion today is can HPV vaccine prevent cervical cancer? So Dr. Amitabh Banerjee is going to cover what is cervical cancer, what are the risks, what about the HPV vaccine, and about its inclusion in the universal immunization program. After Dr. Banerjee has covered his points, we from AIM, me, Deepika, and Pratesh is here too. We would be covering the work that AIM has done in spreading the awareness. I would be kind of talking a little bit about the white paper and the legal documents that AIM has prepared, and Pratesh should be speaking about the legal angle and the compensations that have been paid to in the US in the vaccine courts. But we'll start with Dr. Banerjee. And to introduce Dr. Banerjee, Dr. Amitabh Banerjee is a clinical epidemiologist, is a professor and head of community medicine at Dr. D.I. Patil Medical College, Pune. He has over 2 decades of experience in the Indian Armed Force as a field epidemiologist. He has several awards to his name. So welcome, Dr. Banerjee. Thank you for joining us, and over to you.
Thank you, Deepika, and I am grateful to have this platform on AIM channel. So today we'll be discussing about HPV vaccine, whether we should include it in the universal immunization program. So this is the topic of discussion today, and this will be the talking points. Briefly, what is cervical cancer? Risk factors, cervical cancer, incidents and trends in India, because कभी भी कोई पब्लिक हेल्थ पॉलिसी हम प्लान करते हैं तो हमारे पास डेटा होना चाहिए, तो वी वुड बी टचिंग ऑन वॉट एवर डेटा इज अवेलेबल. एंड देन व्हाट इज द रोल ऑफ ह्यूमन पैपिलोमा वायरस. एचपीवी का मतलब होता है, फुल फॉर्म होता है ह्यूमन पैपिलोमा वायरस, एंड it has been thought to be it has been associated with cervical cancer. So we will see how strong is that association. Then what are the precancerous lesions and their course. This is important because up till now, whatever vaccine trials have been done, they have been done on outcome has been the surrogate measures. That is the precancerous lesions, which most times do not progress to cervical cancer actually. And what is the evidence available? Evidence on HPV vaccines, and what have been some past misadventures while doing the trials, particularly in India. And then there are certain lawsuits going on in USA also. And gaps in the evidence. We will be covering the gaps in the evidence before the past mishaps. And then what should be the recommendation for policymakers? So this would be briefly the scope of the talk today or discussion. So this is the cervical cancer. If you see, this is the cervix. Actually, this is the cervix. And the lower part, this is the uterus with fallopian tubes and ovary on both sides. The lower part is the lowest part is the vagina, and between the vagina and the body of the uterus is the cervix or the neck of the uterus. So cervical cancer is the cancer of this cervix or the neck of the uterus. And this is the which is exposed to the trauma of childbirth or repeated pregnancies. And it is the cervix is also in contact with the male organ during the sexual intercourse. So this is the where there is the thinking is that this is the route of infection with HPV virus, and which is supposed to be associated with cervical cancer. So we will see how much strong the evidence is. So overall risk factors for cervical cancer, that is multiple sex partners is the highest risk, and it can be either partner. Particularly in conservative societies, it may be the male sex partner who is promiscuous, and if he is infected with HPV, he is likely to spread it to his partner who may be faithful. So Then poor genital hygiene, early age of marriage, because early age of marriage is associated with repeated childbirths and repeated pregnancies, and the human papilloma virus has been found to be there in most of the cases of cervical cancer. So on that basis, the presumption is that if you remove or if you prevent infection with human papilloma virus, or if you clear the infection with human papilloma virus, you can prevent cervical cancer. So this is the basis on which the vaccines have been developed and promoted. So we will see there how strong is that evidence. So before that, what is the actual trends? So as on today, that is around 2020, new cases are in 1 lakh women 14.7. हर 1 लाख वुमेन में हर साल 14 वुमेन को सर्वाइकल कैंसर डिटेक्ट होते हैं, और डेथ्स आउट ऑफ दिस इज 9 per 1 lakh. And in the last 3 decades, there have been overall in India, this is the Indian figures, more than 20% to reduction in incidence and about 32% reduction in deaths due to cervical cancer without any vaccine, without any intervention. There is a declining trend, and this is the reference I have given it in brackets. And in some states there is a reduction in more than 50%, in fact. So there is a lot of variation in this trend. Some states have got more than 50 to 60% reduction without any intervention regarding vaccine. It may be due to better hygiene of women, awareness also, because this is a sexually transmitted virus. So people are aware of sexually transmitted infections. So safe sex and other things can bring down the incidence without any vaccination. And just to put things in perspective, I have mentioned second last line, the deaths due to normal childbirth. If you see the cervical cancer in elderly women, we are having 14 is the incidence, and the deaths is 9 per lakh women every year we lose due to cervical cancer. But almost 100 women or 97 women per lakh we are losing in normal childbirth, because we do not have maternal services or obstetric services in the periphery. Women are dying in childbirth, which is quite bigger public health problem than death from cervical cancer today. And to compare, to put things in perspective, the deaths due to childbirth in the developed countries is around 10 to 12. So we have got 10 times higher death from normal childbirth. So if we have to care for the women's health and public health, we have to set priorities. One of the principles of public health is which is the major problem. Normal childbirth, we don't have facilities. We have got a embarrassingly high maternal mortality rate, almost 10 times of the other countries, developed countries, whereas deaths is more or less, as on today, it is more or less in the global incidence and of cases of cervical cancer and deaths from cervical cancer. The global rate as on today is somewhere around 13 per lakh. We are 14, and death is maybe 7 per lakh women. And India, the trend is coming down. So more or less it is as per the without an intervention. And childbirth, normal childbirth, we are losing 10 times more women than we are losing from cervical cancer. And even compared to other developed countries also, our childbirth mortality is very high. So this I want to emphasize, because the budget should be more in the basic gynecological care, obstetric care. And you see deaths, they have done studies, they have found if a normal screening of women in that cervical cancer age group in the 40s and 50s or 30s are carried out every 3 years, the prevention of mortality from cervical cancer can be achieved without vaccination. Vaccination, there are studies which are found from Australia that if the screening, cervical cancer screening is there, you don't require vaccination. Vaccination has no extra advantage over prevention of deaths from cervical cancer, firstly. Secondly, they have also, because it does not cover all the strains of HPV vaccine, human papilloma virus, there are about 100 subtypes. So the vaccine covers only 2 to 3 or 4 subtypes at the most. So even if you give vaccine, you cannot do away with the screening. So we have to see those things also. So let us see what is human papilloma virus as a risk factor. There are more than 100 strains of HPV. Out of this, 16 and 18 are considered as risk factors for cervical cancer. 16 and 18. Others are also considered of lesser importance are 31, 33, 42, 45, 52 and 58. So these are the 6 other strains, but the major 70 to 80% is due to type 16 and type 18. And type 6 and 11 cause the genital warts. So most of the vaccines, Gardasil and Cervarix, they are the 2 vaccines. One is by Merck, other is by GSK. They contain type 16 and type 18, and some quadrivalent contain type 6 and 11. So other types are not included. So this is one of the limitations. Majority of HPV infections are asymptomatic and resolve spontaneously. Without any treatment, they are self-limiting. So the question comes, how much extra is vaccine contributing to it? And prevalence of HPV is also important. Baseline information we should have. From different countries, the prevalence varies from 2% to 42%. So it's not a homogeneous that every woman has got equal chance of HPV virus, because as it is associated with multiple sex partners, unsafe sex, promiscuity, or early introduction, early marriage and repeated pregnancy, and of course the male partner. And so we should have, if the prevalence is 2 to 42%, the universal vaccination to all across the board is not very cost effective. High risk people, commercial sex workers who are promiscuous, behavioral, who have got unsafe behavior, they can opt for the vaccine. It cannot be made mandatory. I mean, there is no scientific basis for mass scale vaccination as on today. Then high prevalence found in patients with cancer and people with HIV. This may be because the cancer also arises when the host immunity is low, and similarly infections also increase. So we don't know which is the cause, which is the effect, because person who has developed cancer is maybe having low immunity and more likely to have HPV infection also. So people with AIDS, more than 50% have been found to be having HPV. So this baseline data is very important. Population variations are there. So this is a very important figure I'll try to explain. This is natural history of precancerous lesions. How the cervical cancer progresses. CIN is the abbreviation for carcinoma. CIN is the abbreviation for cervical intraepithelial neoplasia. C is for cervix, cervical. Intraepithelial means it is still inside the epithelium, and neoplasia is a new growth. So that is the CIN1. That is the very early stage. And on the left-hand side, 57% of it regresses back to normal cervix without any treatment. And even if you did CIN1, no treatment is indicated. No treatment is indicated because they hardly progress to cervical cancer. On the right side is CIN1, the progression is only 1%. And CIN2 is 43% again goes back to normal cervix, and hardly 5% may progress to cancer. So CIN1 and CIN2 do not need any treatment, just observation, and most of them do not progress to cancer. And CIN3 is the actual outcome, that is the later stage of intraepithelial neoplasia, which 12% of times may progress to cervical cancer. So this actual cervical cancer or CIN3 should be the outcome measure for detecting the efficacy of a vaccine. Up till now, there have been no trial because the HPV vaccine is given in preteen women or girls, and the cervical cancer develops after decades, after 3 decades, 4 decades. So the cervical cancer first licensing is 2006, and the vaccination has more or less started in most countries around 2010. So we have hardly got 10 or 12 years, and most of the studies, the follow-up has been less than 10 years. In fact, 5 to 7 years only the study efficacy of vaccines are available, which could not mark the endpoint of actual cervical cancer, but they have taken surrogate markers like HPV virus clearance or CIN1 or CIN2, which are surrogate markers because which in any case regress back to normal cervix. So this is a very not a very robust measure of outcome because you have not taken the endpoint, and most of them are self-limiting. So this is one of the major limitation of the studies. So as we will discuss what are the limitations in evidence, we do not know how well HPV vaccine will protect against cervical cancer. Trials have not focused on outcome of cervical cancer, on the outcome, which is the cervical cancer. They had too few participants and did not follow them up for long enough. They cannot because vaccine has started somewhere in 2006 or mass scale is 2010. So they hardly have. Cervical cancer may take decades to develop. So there are no studies which have followed up. So considering that, roll out of mass vaccination at a country level is a premature with lot of resources which will be involved. And then other limitations are published numbers from randomized control trials may overestimate efficacy because testing occurred too frequently in the trial when in real world settings lesions may regress spontaneously. You see, as I said, natural course also CIN1, CIN2 may revert back to normal. And if you are testing repeatedly and you have given the vaccine to a group, you would attribute that to the vaccine rather than a naturally also it would have regressed. So this will overestimate the efficacy. Then trial use composite surrogate outcomes, some of which such as HP infection and C1N1 occur more frequently than others and are very unlikely to progress to cancer. So because the endpoints were not very high in number, cancer was not there hardly because it takes decades. So even the other endpoints also, some may have some warts, some may have some HPV infection, some may have some cervical erosion, which they took as intermediate measures. So just as composite surrogate outcomes and which are very difficult to say which is related to cancer. So they clubbed a lot of these surrogate markers into one to find out how well the vaccine is preventing these surrogate markers, which hardly any of them are progressing to cancer in real life. And the subgroups were overanalyzed. So they may have taken some age groups, some types of population and try to come, which can also give rise to some distortion in the estimation. Then trial population have limited relevance and validity for real world setting. What this means is that the trials were done in older women and the vaccines are targeted at 9 years of age. Women, girls of 9 to 13 years, and even they recommend for boys also 9 to 13 years because they say it is sexually transmitted. So to eliminate here, you have to give it to both genders. But the trials were done in older women. So that whether those findings can be extrapolated to younger girls is questionable. They did try in younger girls. We'll come to that later in India, and there were certain unfortunate deaths. We'll come to that. And then we do not have enough data on the benefits in women who may have been exposed to HPV before they were vaccinated and who do not know their HPV status. So many women wouldn't know whether they have got herpes virus infection in present or past, firstly. Secondly, these vaccines are recommended 9 years of age onwards to upper. There is no upper age limit. They say you can give it to 25-year-old, 30-year-old. So we don't know whether it will work for women who have already been exposed to HPV or already they have got a irreversible course after HPV infection. We do not know. So there are a lot of uncertainties then. Then we do not have enough data on the impact of vaccine on CIN3, which is more likely than CIN1 and CIN2 to progress to cervical cancer. We also have less data on the impact of cervical disease due to any HPV type other than HPV 16 or 18. So you see, because if they have seen with pneumococcal vaccines that what are the strains causing or including the vaccine due to vaccine pressure, other strains come into prominence. So we have seen there are 100 types of HPV. So we don't know whether giving vaccines only against 2 or 3 strains or types, if they may suppress the other types can predominate. So after a few years, they will say, okay, we have to tweak the vaccine. We will make a new vaccine for the different strains. Now, these strains have come up. So it would be a long drawn affair now. I mean, like we have with the booster doses. So this is again uncharted territory. Then it does not do away with need for screening. So you see, if you give vaccine, you should get some benefit because you will still be spending money on cervical screening. And as I said, they have seen the countries which have got a good cervical screening program. Giving the HPV vaccine did not improve the situation of cervical cancer. There is no marginal advantage of adding this extra intervention where there is no cervical screening program is a must. So again, in India, we have got very poor services of gynecologists. All women do not have access for cervical screening. As I said, we have got a very high deaths from normal childbirth because obstetric services are not there. So before going for these things which are of dubious benefit, we should have the basic health services for cervical screening and normal childbirth. Then there are more oncogenic types, cancer-causing types than covered by the HPV vaccine. As I said, there are 100 types. We don't know yet. As on today, 16 and 18 are predominating, as on today. But because of vaccine pressure, others, they might be suppressed and other types may surface. So then what do you do? So, and then there is good evidence that cervical cancer screening reduces risk of death irrespective of vaccination status. So this is also a very important point. That cervical screening, you cannot do away with. And if you have cervical screening, it reduces death irrespective of vaccination status. The number of cervical cancer deaths have reduced drastically in the last 3 decades before vaccine rollout in India also. So this is already, it's the downward trend. And if they launch a national mass vaccination program, the cases are coming down in any way. And then they will claim, like now they are claiming they have prevented so many deaths from whatever new infection. So they will start claiming that the vaccine have come down, the deaths have come down because of that. So here we have to see, we should have a compass first before launching anything so that we can actually measure whether the vaccine worked or it was a natural. Information from the trials can tell us what happens between 5 and 9 years after vaccination, because most of the trials are up to 9 years, but we do not know if protection wanes after this time. So you see, after 9 years, we don't know what will happen with the vaccine immunity. You see, in COVID, after 6 months, we are coming to know after 6 months, there is no immunity. So when after 6 months, we cannot guarantee how we can say what will happen after 10 years. I mean, these are some of the questions the people should ask. A recent study provides some evidence of observation study efficacy in girls vaccinated before sexual debut. This study is done in Sweden, Karolinska Institute, but this study also followed up women up to 30 years only. It's a 10-11 years follow-up. So here, again, the numbers were very small and it was an observational study, because observational studies are not, there can be other confounders, other factors. So this study is very much been stressed upon, but this again has got a lot of limitations. Then ongoing observation studies may tell us about the long-term effects on rates of cancer. This study has to be actually 3 decades or 4 decades, then only we'll know, but many years before we have the evidence. So before we have the evidence, why we go for a mass vaccination? Past mishaps. What has been the Indian experience? HPV vaccine trials among adolescent tribal girls undertaken in low-key manner in India in 2009. It was in Andhra Pradesh and Gujarat. This was carried out by Path Foundation, which has got links with the Gates Foundation, conducted a trials in collaboration with ICMR. So this is important that all research bodies have already got conflicts of interest, and this started in 2009. It was described as an observational study instead of a clinical trial to circumvent ethical issues. So this is something which has got major ethical concerns. Because firstly, you are doing it in a tribal girl, which themselves are ethically questionable because they are vulnerable population. Secondly, they are young girls, so whether informed consent they are able to give or not. And then thirdly, they have been promoted by the vaccine manufacturers, the Path and the Gates Foundation. So then they have misrepresented the study as an observational study instead of a trial. Because how can it be observational study? Observational studies are this, like in normal course, a person is taking some vaccine or drug and you are just observing, you are not intervening from outside. Here you have brought a vaccine and giving it to a tribal girls, that itself becomes a clinical trial. Any new intervention, it itself becomes a clinical trial, and it raises serious ethical issues if it has been mislabeled as an observational study. Then during the trial, few girls died after receiving the vaccine. None reportedly had any prior illness. All were residents of government-run hostel for tribal children. They were hostel girls, so perhaps their parents also may not have been consulted. Stakeholders, that is the Path Foundation, Gates Foundation, and the ICMR, claimed that the deaths were unrelated and coincidental. But still, there was a lot of people outcry, and the central government halted the trial. ICMR claimed that deaths were coincidental. That is the usual reply. People demanded an independent inquiry, even as the state government also tried to cover it up, said the girls committed suicide. So this has happened in 2009, and now things are more worse than 2009 also. Other side effects included, besides death, there were some girls had epileptic fits, mood swing, and stomach illness. The tragedy, due to the pressure, public pressure, the tragedy was investigated by the Parliamentary Standing Committee on Health and Family Welfare. It submitted its report titled Alleged Irregularities in the Conduct of Studies Using Papillomavirus, HPV, by Path in India to both houses of Parliament, August 30, 2013. There 10 years have elapsed, and it had recommended, and it found that ICMR had signed an MOU with Path in 2006 to support the trials before the Drug Controller General of India had approved the vaccine. So before that, already they had, and this report is available in the public domain. I will give the references in the end, so anybody can access the report, or you can just type the Parliamentary Committee report and some keywords on Google search, the report comes. It also questioned the ICMR role in trying to promote the inclusion of vaccine in the universal immunization program before any independent study about its efficacy. So imagine in 2013, the Parliamentary Committee questioned the ICMR's role in trying to promote it for inclusion. Today, nobody is questioning it. Before any independent study about its efficacy, as on today, no studies have been carried out in India or independent study about its efficacy. Only things, whatever studies are being done in Western population, they are, and the vaccines are pushed on that. And we have seen just now, even in the Western population, the studies have got a lot of uncertainties. So, which really does not call for mass vaccination. At least if you have to, you may market the vaccine, but you give it as per choice, not as a government taxpayers' money. Because then, if you give it to everyone, you are removing all chance of a control group also, like they did with the COVID vaccine. There is no control group. Everything is attributed to COVID or long COVID. So here also, if we do so prematurely and so fast for young girls, again we will lose the control group. Committee noted that all 7 deaths were dismissed as unrelated to vaccination without in-depth investigation. So how careless they can become. According to the inquiry committee report, the speculative causes were death, suicide, accidental drowning, malaria, viral infections, subarachnoid hemorrhage without autopsy, etc. The committee also noted that suicidal ideation is caused by many drugs. So even if, let us say, girls have committed suicide, that could have been due to the ill effect of the vaccine. So that we cannot assume. Then Parliamentary Committee recommended that the matter be inquired by a premier investigating agency, but it has almost been a decade since then. No such investigation has been carried out yet. Meanwhile, they seem to have built stronger alliances. While the MOU between the ICMR and Path was looked at critically by the Parliamentary Committee a decade back, there seems to be a scant respect for such censure. Because recently, ICMR signed a declaration of intent with Bill and Melinda Gates Foundation and US-based NIH in research collaboration. So they were actually reprimanded 10 years back for collaborating with Gates Foundation. Nothing happened, and now they are again signing collaboration for research. And lobbying is underway to include the HPV vaccine in the Universal Immunization Program. So this is medical imperialism, something like colonial times. So what is happening now, as far as academics are concerned, British ruled India by giving sultanates to petty Indian kings. These local satras were effective at maintaining British rule and gained much from loyal to the British. British signed treaties and made military and alliances. So now the researchers and the scientists are doing that, what the Indian rulers did during colonial times for getting some petty benefits or sultanates. So now the scientists are getting grants, huge grants. 80% of research is sponsored all over the world by Bill and Melinda Gates Foundation. ICMR also is getting a lot of grants from here. So do we expect independent research? Very difficult. So we are in the era of medical imperialism. Today we are witnessing the era of medical imperialism where MOU and grants for research are being offered by foreign donors as long as the recipients listen to their master's voice. So this is what has happened to research in mostly all countries. And similar, what is happening in USA? USA, there have been a number of lawsuits. New research has claimed that Gardasil can possibly induce an increased risk of autoimmune disease and other serious complications, number of them. And of course, the CDC maintains there is no relation between Gardasil and autoimmune disorders. The US NIH Library of Medicine echoes the CDC's view on the subject. Like in India, ICMR is highly compromised. The CDC also gets a lot of its funds from the vaccine manufacturers. Merck, it has been alleged that Merck could have obtained FDA approval for Gardasil. Even FDA is heavily funded by the pharma companies. Based on deceptive research and clinical trials, which seemingly misrepresent the efficacy of the vaccines while concealing its adverse effects. And according to reports, some marketing campaigns for HPV vaccines appear to have been led to millions of parents opting to vaccinate their preteen daughters. This is in USA. These concerns eventually snowballed into the Gardasil class action lawsuit in the US. So a number of lawsuits are going on. What is the present medical consensus? I tried to do a lot of standard textbooks. So the medical consensus, because we are against very heavy odds. I mean, not that we want to oppose vaccination, but we want the correct evidence, strong evidence before taking such a major step, which is not only hazardous for young children, but which is a lot of drain on the taxpayers' money. So what is the medical consensus? It favors adoption of HPV vaccination program for pre-adolescent girls and also boys without adequate evidence of its efficacy. However, all the textbook will say that it is the thing to do. I talk with number of gynecologists who are cancer specialists because they have got a very limited vision. Yes, if a vaccine is available, because they see cases of cancer cervix, so they think if you give a vaccine, this could have prevented. But in the large population data, the association of vaccine efficacy is first not firmly established, and it is not so neat also. The WHO and standard textbooks recommended it. It is included in vaccination program of 125 countries. And the WHO says it will prevent 45 million deaths in the next 100 years. So it is making a 100 years prediction. And 45 million deaths, as it is, we see the trends, past 3 decades in India, the trends are coming down as it is. So with better standard, better hygiene, better awareness of safe sex, it will come down in any case. So very difficult to say the vaccines will prevent it, but WHO says that. And WHO is an honorable body. So this is the very standard textbook, which is a Bible of vaccines, which I have been my medical career for 40 years. I used to read it. But when I went to the library to check the latest edition of Plotkin's vaccines, this is a very thick book. And it is I read the chapter. on vaccine, it does recommend strongly HPV vaccine for prevention of cervical cancer. But I don't know whether you are able to see the lower part of the cover. Could you see the lower part? It is saying forward to this book. The forward to this book has been written by Bill Gates. So I was really surprised. Now, medical textbooks, standard textbooks, Bill Gates is writing the forward to a textbook on vaccines. And one can imagine the amount of conflict of interest of all the authors also. And there have been published studies which says the standard textbooks of medicine, 50% of authors or contributors of the textbooks are in some way or the other related to are getting grants from pharma companies. So there is heavy conflict of interest. So this again, we have to take with a pinch of salt, but these are very strong factors we are against Goliath of medical whatever consensus. So what we suggest from whatever limitations in the data is that establish first, before we launch a program of mass vaccination, we should have a proper infrastructure to monitor what is happening. Firstly, what are the trends that establish? First, we should establish a national baseline on cancer incidence proper, because what estimates I saw past 3 decades are from the Global Health Report of the WHO, which are very crude data. Even that is showing incidences coming down in India past 3 decades. But we could have a more robust registry, cancer incidence and cancer mortality. And also we should have periodic surveys all over the country for different HPV subtype prevalence, because there are more than 100 types of HPV virus. And from literature in the Western country, you are saying 16, 18. Unless we do our own research, we won't find. Maybe some other strains are causing cancer in India. Maybe not those strains. So you see how much we are going just like, blindly we are going for something without having baseline data. So we should ask for, at least this can be done very rapidly, what are the types we have got. This will decide whether the vaccines will be cost effective and should be a priority. Then ensure cancer surveillance and registration are in place before any mass rollout of vaccine. You see, just mass rollout of vaccine without any public health infrastructure, surveillance infrastructure for capturing the adverse events following immunization is just like rolling out, fast trains without having proper rail tracks. And we had the rail tragedy in Orissa recently. So at least rail tragedy comes to light, and very unfortunate, but there are mass casualties at one place. But if you don't have proper surveillance, proper monitoring, so there are mass casualties all over the country without coming to public notice. So, and as we saw, even under trial conditions, any deaths occur, they are shoved under the carpet as coincidental. So you can imagine in normal times how difficult it is to establish a vaccine as the cause of adverse events if there are no proper system in place. We should initiate national long-term efficacy and effectiveness studies free from industry funding. This is very important. Where to get it now? Like ICMR is heavily funded by Gates Foundation. So where we should ask for research funding from taxpayers' money rather than vaccine funding by taxpayers' money. So research has to be funded. Then, of course, vaccine may be by whatever private company, but the basic foundational research should be free from conflict of interest. And AFE reporting should be in place before we launch out a mass vaccination. These are some of the references. This first reference is very important. Most of my presentation has been made from the first reference. This is a 12 randomized trials. They have tried to summarize, and all my slides have been taken from this paper. I have just highlighted that, and this has been published in a very reputed Journal of Royal Society of Medicine and there have been no funding for the study. Other is just a column I have written. I have given the reference, but why I have given this, because this reference contains the second reference, which I have just written a column. It contains all the links to the other references which I have cited, such as the lawsuits taking place in USA, then the mishaps which occurred in India, the links are given to that. Then the link to the parliamentary committee report is also given this. In one place you will find all the references, because whatever I have given in these slides are from references which can be rechecked. Thank you.
Thank you, Dr.